Happy Tuesday.
Hi, good morning.
Good morning. Here we are again.
On a very, very special Tuesday.
Yes, absolutely. Absolutely.
It's our last Tuesday for our Instagram Live where we're talking about Endometriosis Awareness Month.
And today, the third episode of our podcast, My Fertility Podcast, was released, and it is specifically about endometriosis. We had an interview with endometriosis expert, Dr. Geoff Zeni, here at Markham Hospital, and he was amazing.
Oh, yeah.
It was such a good interview. The first part of that was released today, and it is all about explaining endometriosis, what is silent endometriosis, what is deep infiltrating endometriosis mapping in detail. Mm-hmm. And he also tells a story about Dr. Weiss. So listen until the end.
Yeah, Dr. Zeni and I have known each other for a long time.
Just when I thought I knew everything about you.
Yeah.
And learn more things.
Wow. I'd like to keep things interesting.
So today we are going to talk about the treatment of endometriosis in the context of infertility treatments or IVF and things like that.
Mm-hmm. And so, I think when we were starting to think about this, we really want to break it down sort of by fertility treatment or fertility assistance in terms of what people are doing. So, for instance, you may have a patient with endometriosis. Let's say they have a pelvic ultrasound and you see an endometrioma, so you know they have endometriosis or they have a history of endometriosis. But maybe they're coming and they're going to be doing timed intercourse, let's say. So in an endometriosis patient, when would you think about timed intercourse?
I think if they are relatively young, if they haven't had a long history of infertility, if they're ovulating regularly, or even if they're not, we can always give you medication to induce ovulation. But certainly, and then we go into detail about this on the episode, like having endometriosis doesn't automatically mean that you have infertility or that you automatically need to have surgery and IVF and that's the only way that things are going to happen. And again, the stage of the endometriosis doesn't really correlate with the degree of pain you might experience and the degree of infertility that you might experience. Mm-hmm. So I think it's important that patients with endometriosis still have all fertility options available, with time intercourse or IUI being the least expensive, least invasive fertility option, and there is no reason to deny that treatment with somebody with endometriosis as long as we have proper informed consent and we talk about things like ovarian reserve and age and quality of the sperm and chances of conception, which we know are going to be low, endometriosis or not, right? In time intercourse and IUI cycles, pregnancy rates are usually about 10%, 15%. Mm-hmm. So, I think those options are definitely available for people with endometriosis.
Yeah, absolutely. And I think, the one thing that's worth highlighting is that in a timed intercourse cycle or an IUI cycle, there's not really anything special or particular that we're going to do for somebody just because they have endometriosis. Maybe potentially we would just sort of be keeping an eye on pain and managing pain associated with endo. But there's no particular medication or different protocol that we would use in a timed intercourse or IUI cycle.
Right. So then after time intercourse and IUI, then the next option is IVF. And IVF, there's some considerations for IVF in the context of endometriosis. I wouldn't say there is one specific perfect IVF protocol that you must use in all people with endometriosis.
I sort of wish there was.
That would make our life easier. But there isn't.
And I think that that's part of the challenge, part of the art of medicine, But there is no specific best protocol for IVF or transfer for anything. And that's really, really important to highlight, I think.
Yeah. So there's a few considerations in the setting of endometriosis and IVF outside of the protocol, which we can talk about a little bit more. One of the considerations is, for example, the risk of infection. So when you have endometriomas, which not everybody with endometriosis has endometrioma. So endometrioma means a cyst within the ovary that contains endometriosis within the cyst. So you can have ovaries with endometriomas, or you can have the condition of endometriosis, but the ovaries are not affected. So regardless of either one of these things, but in particularly if you have endometriomas in the ovaries, there's an increased risk of infection during an egg retrieval. So we would want to be aware of that, counsel the patient about it. We do IV antibiotics at the time of retrieval, in addition to oral antibiotics prior and after retrieval as well, to minimize the risk of infection.
Another concern around infection and another consideration for an egg retrieval would be if somebody has a swollen fallopian tube. So sometimes in endometriosis, you can have scarring in the pelvis that can cause the fallopian tube, which is normally open on both ends, let's say become blocked off on one or both ends, and then fluid will sit there, fluid will build up, and they can become quite swollen. And that's something called a hydrosalpinx. And so when somebody has a hydrosalpinx, there's also a higher risk of infection. And that would be another reason why we'd give somebody extra antibiotics at the time of an egg retrieval, because again, the oftentimes this hydrosalpinx will sit sort of on top of the ovary, and there's always a possibility that we can potentially poke it, essentially, and cause a little bit of that fluid to come out of the pelvis, and there can be a slightly higher risk of infection. That would be another big thing that I'd be looking for.
Mm-hmm. Another consideration as well is access to the follicles. So again, if you have ovaries and there is a cyst in them, there might be the cyst on one side and then the follicles around it. So you're trying to put the needle into the ovary to aspirate the follicles that contains the eggs. And sometimes access to those follicles can be difficult when there is an endometrioma present and you need to go around it, and it might be hard to get to them. If you go through the endometrioma, that's something that we try to avoid at all costs, because it increases the risk of infection. And also sometimes the ovaries, because of endometriosis, they can be immobile or stuck, and that makes it more difficult to move them around the pelvis in order to facilitate the access. So access can be an issue. Sometimes this can be dealt with by doing an abdominal retrieval. Sometimes you can get some follicles, but not all of the follicles. So that's also a conversation that I have with all patients when they're starting the IVF journey in the context of having endometriomas.
Yeah. It's a really, really hard one, though, because you can see where the endometrioma is, but you can't predict where the follicles are going to grow, whether they're going to be up here or whether they're going to be down here and really easy to access, or whether they're going to be over here and again easy to access. And the ovary moves around as well, sometimes, depending on how stuck it is, as we said. And so that's why trying to give somebody a really good prediction whether we'll be able to get the eggs or not is impossible. And I often will sort of say, we don't know until we're there on the day of, unfortunately, in terms of what we can access. But what I will say, the really, really good thing is that patients, for instance, who are doing their egg retrievals here at Markham Fertility, because they're under deep sedation, they're much more comfortable. And so it's a lot easier and a lot more doable, basically, to try and move the ovary around to get to those follicles, or to do a transabdominal retrieval, meaning, needle right through the abdominal wall to access the ovary. And I think that we can't guarantee that we're going to get all the eggs, but we can do a lot to be able to get as many as possible here, more so than other places, I think.
That's right. Yeah, because they're sleep, which is great.
Yeah.
Another consideration for IVF in the setting of endometriosis is pelvic pain. So pain, unfortunately, is very familiar with people who have endometriosis, and in the context of being stimulated for an IVF cycle, those ovaries are growing, you've got more follicles, they get bigger, and if you already have a lot of scar tissue, inflammation, and pain, the stimulation for somebody who has endometriosis and pelvic pain can be more painful. So that is something that I also talked about to my patients, sometimes being off work, sometimes being aware and that is going to happen, and using heating pads on a regular basis, maybe even using pain medications during the stimulation cycle is also important to be aware of.
Absolutely, for sure. And it almost like it sometimes causes the endometriosis to flare a little bit.
Yeah, and after the retrieval, you can have a lot more pain as well.
Yeah.
Patients with endometriosis. So while we don't normally prescribe narcotics post-retrieval routinely because it's not necessary, definitely somebody with endometriosis, if I know that they are having a struggle with pelvic pain, I'll bring it up.
Yeah. Yeah, always better to be prepared when it comes to pain than to be surprised by it.
Yeah. So in terms of protocols for IVF in the setting of endometriosis, in general, there's two main types of protocols. There is what is called the agonist suppression protocol and the antagonist suppression protocol. And in the old days, I'm very young, so I didn't get to see a lot of that. You're even younger.
No,
Stop
you are
laughing at me.
She's
laughing at me because she's younger than me and she likes to rub it in my face. See? Busted. Everybody can see it now. You're laughing at me. Wow.
Listen, I
have witnesses. Instagram is my witness.
Listen, I'm calling you my sister. Like, that means I see myself as the same age. We're all in the same group. Yeah. There you go.
So the agonist protocols, they used to be used a lot more many years ago, and then they fell out of use because the antagonists are so much easier. So an agonist protocol will be something like lupron suppression. They take longer. They have a lot of side effects like the hot flashes and the symptoms of menopause. And then the antagonist protocols, they are shorter and they're very effective in preventing ovulation. So there used to be this thought that in endometriosis, you absolutely had to use an agonist protocol and even like 3 months of suppression prior to starting an IVF cycle. That used to be the sort of the gold standard many years ago. But new studies have proven that that is not the case.
Yeah.
And there's actually never been a really good study that say, okay, this is the protocol that you have to use for all patients with endometriosis. So I tend not to use a lot of suppression in patients with endometriosis. Especially suppression can make your ovaries more difficult to stimulate. And if you have endometriosis and difficulty with access and not great ovarian reserve, then suppression can really be counterproductive to the goal.
Yeah, absolutely. And I think the bottom line is really there is no specific best protocol for IVF stim for patients with endometriosis.
That's worth mentioning again. Yes.
And in fact, with the long agonist protocols, one of the, right now, so basically worldwide, I would say, or not worldwide, but at least in North America, in the world of IVF, probably 95% of IVF cycles, and this is not just a Markham thing, I'm talking, North America wide, probably 95% of IVF cycles are going to be antagonist protocols. And so one of the big benefits of the antagonists is reducing risk of ovarian hyperstimulation syndrome, which we usually think about a patient who has endometriosis as having a low egg reserve, but the two are not synonymous. And, I've absolutely had patients who have endo, but who have a high egg reserve. And if I put them on an agonist protocol, they would be at much higher risk of overstimulating and having OHSS symptoms. So, that's just to say that every patient with endometriosis is unique. And so when we're talking about protocols, these things, we do try and personalize the patient as much as possible. But, people often ask, what's the best protocol for an endo patient? There isn't one. There simply isn't one.
Absolutely.